TNBC, or triple negative breast cancer, in terms of the histology, genomics, and the clinical characteristics. And then instead of drawing on the National Comprehensive Cancer Network algorithmic way to approach triple negative, I'm going to introduce you to something that is being rolled out in the United States in an effort to reduce the differences in how people are treated, and it's called Pathways. We participate in a national pathway program called VIA, and I'm actually going to show you that as a way to approach new treatments that have come up and have been established now as standards of care in the United States for newly diagnosed disease, for the adjuvant and the post-neoadjuvant setting, and then approaching metastatic disease. We'll do this by highlighting some of the more recent clinical trials, and then I'm going to touch on a couple of the controversies regarding these trials and the approaches. So here it is in terms of triple negative breast cancer. It's classically defined as the lack of immunohistochemical expression of ER, PR, and HER2. Within pathologists and within our studies, we need to be very careful when we read who is eligible for clinical trials, especially as it relates to ER and PR. Typically, ER negative and PR positive in some studies and in some clinics are considered as hormone receptor negative. Low ER or PR expression as well, below 5% or even below 10%, would also may qualify some folks as having triple negative breast cancers. It's approximately 15% of the breast cancer types worldwide. It's aggressive with a high recurrence rate. And there is a genomically distinct subtype that is associated with IHC-defined triple negative breast cancer. The molecular definition of that is basal. It is more common in young people in the United States. It's more common in the Black and Latinx community. And this should trigger a referral for genetic testing among newly diagnosed patients because it is highly prevalent in those who have mutations in BRCA1 or 2. So here's a question that I kind of mentioned before, which is how synonymous is triple negative breast cancers to basal breast cancers? Are we correct when we describe a triple negative as basal? The idea of a basal subtype of breast cancer is now an old one, and it comes out of Charles Perrow's original data, where he identified the subtypes of breast cancer based on molecular classification. And he came in, so this is where we got the terms basal as well as luminal, A and B, as well as a HER2 and a normal-like breast cancer based on whether genes were up or down regulated. Now, this study by Pratt, now almost 9 years old, looked at the clinical and the subtype status. So clinically, IHC defined as triple negative, and then wondered how many of these fall in or are consistent with being basal subtype cancers. And he did the analysis in reverse as well, where there were subtype status defined by molecular characteristics, and then he tried to associate them with clinical status. And here's the most important thing. These are not synonymous phenotypes, okay? So an IHC-defined triple negative breast cancer and a molecularly defined basal breast cancer using the PAM50, which is a genomic test that's widely available now, that really came through Perrow's original data set, shows that 79% of triple negative IHC defined triple negative breast cancers are basal. That means up to 20% are not. And if you look at the reverse of basal breast cancers, 69% of them could be classified as triple negative. Again, something to keep in mind. Practically speaking, if I do meet someone with triple negative breast cancer, I might use the term basaloid rather than basal, just keeping this in perspective. So this is the VIA medical oncology pathway that I mentioned. So again, this is worked on by about 50 or so institutions within the US. And it describes not only the context of the decision. Here, it's someone with HER2 negative unknown, equivocal, ER, negative or unknown. And here they started with, this is a person that I am thinking of giving them neoadjuvant chemotherapy. Here are all the options for treatment. The main option that is being recommended is number 1, which is dose-dense ACT, but they're giving the Taxol prior. They do provide multiple alternatives based on the clinical setting. Now, the reason that I started here, I'm going to get to in a moment, but all of these regimens that are listed are also reasonable suggestions for the patient who undergoes surgery first and is undergoing adjuvant therapy. Now, here is another pathway which incorporates platinum therapy. So the way it is structured is, if you are thinking neoadjuvant treatment for someone with a triple negative breast cancer and you want to give a platinum, there's a pathway for that. Okay, so if high-risk disease is not present, and I'll mention what that criteria was in a moment, they provide the option of doing ACT or AC, followed by carboplatin with weekly paclitaxel. They also provide the following editorial. Neoadjuvant carboplatin in multiple clinical trials has improvements in the pathologic complete response rate in these folks. The reason it is not standard is because none of the trials show this translates into an overall survival advantage. So they are recommending the incorporation of carboplatin only for higher stage disease in the neoadjuvant context. So what if you take the same person, but now you're saying, I'm worried about her. I'm worried about this patient with triple negative disease because of high risk features. This is where the first trial I'll talk about comes in, and it has led to the incorporation of an immune checkpoint inhibitor, pembrolizumab with Taxol carbo for the first 12 weeks, followed by pembrolizumab with AC for the next 12 weeks, followed by surgery. The data that comes out on this is from the Keynote 522 trial, but let's take a step back and ask about who are these folks where I would be wanting to provide neoadjuvant therapy. Remember, the widely accepted endpoint for neoadjuvant treatment is to downstage the breast tumor to allow breast conservation. Using that definition, it is widely accepted that you take into account the tumor to the breast ratio to make that determination. But for T2 or higher lesions, downstaging may help the surgical procedure. Now, in addition to that, we know certain subgroups of breast cancer have much more likelihood to go into a pathologic complete response with chemotherapy provided in the beginning before surgery. Triple negative breast cancers are one, the other being HER2. So using this, that you have a more higher likelihood of a PCR, a widely accepted indication is also to clear the lymph nodes. So in our practice, T2 or higher, with or without node-positive disease or node-positive disease, regardless of the tumor size, we are incorporating neoadjuvant chemotherapy. The area of controversy then is, what do you do for triple negative small tumors that are node negative? And the question is, do you need to give them chemotherapy? If you think you need to give them chemotherapy, most are providing that chemotherapy prior to surgery. I will point you to this article that was published last year using the United States surveillance epidemiology and end results data with about 4 years of follow-up. And what I'm showing you here, and I think it is a fairly elegant analysis, they looked at T1 node negative, triple negative breast cancers, less than 5 millimeters, up to 10 millimeters, greater than 10 millimeters. And I'm going to point you to the two analyses that they did. Overall survival, and then probably the more relevant one for this group, breast cancer specific survival. Okay. If you look at BCSS, there is no difference on whether or not folks got chemotherapy for small, less than 5 millimeter tumors. There was an overall survival. But again, many things play into the survival for our patients with breast cancer. So if you look at breast cancer specific survival, they did as well without chemotherapy as they did with chemotherapy. Slightly higher at T1B, again, no benefit to the use of chemotherapy for T1B node negative, triple negative breast cancers. But at T1C, you are starting to see a statistically significant advantage to the use of chemotherapy for these small tumors, but above 10 millimeters. I think this is highly relevant data and argues against the use of neoadjuvant chemotherapy for very small triple negative breast cancers, in which case I prefer they go to surgery and then we readdress the question when final pathology is available. Because again, here's the bottom line from this study for me is that small triple negative breast cancers may not need chemotherapy at all. And here's the forest plot by T1A-BC crosses 1 with T1A. If you look at overall survival, and it crosses for breast cancer specific survival, and the only group in whom chemotherapy appears beneficial is T1C. Using that analysis, it explains Keynote 522's eligibility. This led to the adoption of pembrolizumab in the neoadjuvant context for these patients. Keynote 522 enrolled over 1,000 people worldwide, and they included T1C, not smaller tumors. You had T1C node positive, and if you were node negative, you'd have to have a larger tumor. This is classified as the high-risk features that were mentioned in the VIA pathway guidelines. So, small tumor, but node involved, or large tumor, regardless of nodes. Bilateral, multifocal, inflammatory breast cancers also were included in this trial. The treatments was pembrolizumab given every 3 weeks during neoadjuvant chemotherapy, then every 3 weeks for an additional 9 adjuvant cycles. The control was placebo given at the same time, and the chemotherapy was for 24 weeks. In the first 12, Taxol weekly with carboplatin every 3 weeks, and then the following 12 weeks, AC, not dose dense, was given every 3 weeks for 4 cycles. And the reason really is the timing of pembrolizumab to be much more patient acceptable. Median follow-up was 15 and a half months. And if you look here, this is pathologic CR rates higher with the use of pembrolizumab. So this accepts DCIS in the classification of PCR, 65 versus 51. If you want to adopt a more stringent criteria of no carcinoma, node negative, it was still 60 versus 45%. And if you just concentrate on the tumor, it was 69 versus 54. The difference was consistent. It was a 14 percentage point advantage to the use of pembrolizumab as neoadjuvant therapy. If you look at the subgroup analysis in whom pembro appeared better in terms of pathologic complete response, node positive, T1, T2. Remember, if you had a T1 tumor, you had to be node positive. Weekly carboplatin was allowed, and that appeared to be better. PDL1 positive, younger patients. This is the event-free survival, which was defined as any recurrence or development of metastatic disease or the death of the patient. And at 18 months, event-free survival was 6 percentage points higher in the pembrolizumab arm. The most common event here was recurrence. And in terms of the safety analysis, there were no new safety signals seen. Most of the adverse events with pembro was seen in the neoadjuvant context, although treatment-related adverse events still occurred even with the placebo in the adjuvant phase, but it was similar. All right, moving on. So that literally covers the neoadjuvant as well as the adjuvant approach. What do you do after neoadjuvant chemotherapy, though, for the patient who has residual disease, for those patients who do not undergo a pathologic complete response? Here we go. So this is the HER2 negative cohort, and we're going to go down to the ER negative or unknown. And then we ask the question, do they have a BRCA mutation? Did they receive neoadjuvant pembro and chemo, or did they not receive neoadjuvant chemo? So here, if you go to this bar, they suggest capecitabine. If you got neoadjuvant pembro and have residual disease, it's pembrolizumab to continue, not pembrolizumab plus capecitabine. And if you had a BRCA mutation, they recommend olaparib. So let's get into this data as well. The first is the role of capecitabine, and the study that is most commonly cited is CREATE-X, which is here, published in the New England Journal of Medicine in 2017. So this took patients with HER2 negative breast cancers who did not undergo a pathologic complete response after anthracycline and or taxane containing therapy. The exclusion criteria: bilateral breast cancers, other malignant conditions, or prior treatment with 5-FU. The intervention here was up to 8 cycles of capecitabine versus none. Endocrine treatment was allowed if you were ER positive. So with a median follow-up of 4 years, and I'll just point you to graphs C and D, among triple-negative breast cancers, and I want you also to remember these figures: 70% 3-year disease-free, 79% 3-year overall survival. Now, if you look at the full analytic set, which included patients with hormone receptor positive disease, it was statistically significant. Hazard ratio did not cross 1.0, but the overall benefit was seen in patients who had hormone receptor negative disease. And that's actually shown here in the subgroup analysis by, if you look at hormone receptor status, CAPE was better. Didn't see it if you're ER positive. Safety results are also seen here. Needless to say, it was far more toxic than not doing anything at all. Mostly with neutropenia, but the diarrhea was significant at 3% versus nil. And of course, hand-foot syndrome, 11% versus nil. So this has been widely adopted as the standard of care recommendation in the US, but I will suggest, and I do this every time I speak on breast cancer, specifically on capecitabine, this was only one trial that looked at the neoadjuvant or the adjuvant after neoadjuvant application of this drug. The GuyCam-Saboma trial was done in Europe. It took patients with node-positive triple-negative breast cancer who had residual disease and provided adjuvant CAPE, again, for up to 8 cycles. 5-year disease-free survival was unchanged. It was not statistically significant. Neither was 5-year overall survival. The interesting thing about this trial is they looked at molecular subtyping, and if it looked like triple negative disease that was not basal-like, those are the folks who seem to benefit. Again, going back to that original Pratt analysis we talked about a bit, showing that not all triple negative breast cancers are basal, that there is a subgroup that are non-basal. And this study suggests that it is the non-basal-like disease that benefits from capecitabine. In addition, just presented at ASCO this year by Ingrid Meyer was the Eastern Cooperative Group Akron clinical trial, which looked again at the adjuvant application of treatment in patients with residual disease of at least 10 millimeters after chemotherapy. Here, they gave platinum for 4 cycles in the adjuvant context, or capecitabine for 6, not 8 cycles, 6 cycles. Here are the outcomes. It was a negative trial. Carboplatin did not do any better than capecitabine, but we also did not see an 80 or 70 to 80% benefit with the use of capecitabine. We saw half that benefit. So again, I think what we're seeing is 3 different populations looking at the same drug, and the only trial where capecitabine was effective was an Asian study that enrolled Japan and Korean patients. A European study that enrolled Spanish patients predominantly was negative. And then you have this US study that is also showing suboptimal results with the use of capecitabine. I'm going to leave that there. We can talk about it if we have any questions. So here I'm focusing now on what do we do with patients who have completed adjuvant chemotherapy and have a BRCA mutation. Here, high-risk disease defined as hormone receptor negative, node positive, large tumor, or hormone receptor positive with 4 or more positive lymph nodes. Now, that can be at the time of original surgery, or these criteria can be met if they got neoadjuvant chemotherapy. The recommendation is 1 year of olaparib, which is a PARP inhibitor, indicated in breast, prostate, ovarian cancers, in tumors with tumors with a genomic or a somatic BRCA mutation. This was based on the Olympia trial, which was published this year as well. So Olympia took patients with a pathogenic or likely pathogenic genetic BRCA mutation, meaning this was found in their saliva or their blood. Completion of all local therapy, no more than 12 weeks. If they received neoadjuvant chemotherapy, no chemo was allowed after the surgery. So this is a population where, in a lack of a pathologic complete response, in order to get on this trial, they were not given anything further. They were not given capecitabine specifically. If not treated with neoadjuvant chemotherapy, again, we went through the criteria for what would have been deemed high-risk disease. The intervention was 1 year of olaparib or placebo. And here are the results for Olympia at 3 years for invasive disease-free survival, distant disease-free survival, and then 3-year overall survival. So 8 percentage points advantage for invasive disease-free survival, 7% advantage for distant disease-free survival, and at this time of follow-up at 3 years, with only with very less than 100 deaths in both arms, a 4 percentage point improvement in overall survival. Statistically significant for both disease-free survival endpoints, not statistically significant for overall survival at the time of follow-up, but recognize that all people are doing very well. If you look at the subgroup analysis, olaparib essentially looked good in almost everybody. It crossed 1 due to numbers, probably, in the hormone receptor positive group. Couldn't say anything in the hormone receptor positive group who got adjuvant or neoadjuvant chemotherapy, but definitely helped the patients we're talking about who had triple negative breast cancer and received either neoadjuvant or adjuvant chemotherapy. If you look at the toxicities compared to placebo, absolutely you're going to see toxicities far higher if we just left people alone. Mostly it's nausea, fatigue, diarrhea, headache. Not much in the terms of severe neutrophil or neutropenia, but this is still treatment. So let's move forward now beyond the curative intent setting and see what we have now in place for the treatment of metastatic triple negative breast cancer. One of the major themes that have come up now that PARP inhibitors are available is the importance of genomic testing. So in our practice, we are routinely sending patients with a first diagnosis of metastatic breast cancer for genomic testing of their tumor. These are very rare, but the implications are quite important for a mutation in BRCA within the tumor, for the finding of high tumor mutational burden or microsatellite instability. The rarest thing you've ever seen, although there is a great case out of Bangladesh of an NTRK gene fusion protein, and then and those are really the main ones we are looking for. Beyond that, we are resorting to chemotherapy. These are patients who are not eligible for endocrine therapy. At this moment, they're not eligible for HER2-directed treatments, although this may change with some of the newer drugs on the market, especially the antibody drug conjugates, which might show activity in what's called HER2 low disease. So this is HER2 1 or 2 plus by IHC, FISH negative for HER2. We may be seeing a new class of drugs coming up for HER2 low. For now, for ER negative disease, we look at PD-L1 expression because we can give pembrolizumab with chemotherapy. If it is negative, we're resorting to weekly Taxol as a primary recommendation in the first line. And in the second line, we're looking at capecitabine, adriamycin, or eribulin. So the data that looked at pembrolizumab plus chemotherapy was Keynote 355. It was published in 2020. Again, an international phase 3 clinical trial. The main volunteer criteria, 18 centrally confirmed diagnosis of triple negative breast cancer, at least one measurable lesion, no prior adjuvant treatment in the 6 months before they enrolled, no prior immunotherapy using a PD-1, PD-L1 inhibitor. The treatment was pembro plus chemo versus placebo plus chemo. And the chemotherapy used was NAB paclitaxel, weekly paclitaxel, or carboplatin plus gemcitabine. So here are the results for CPS 1 or CPS 10. And what you're seeing is a statistically significant advantage to the use of pembrolizumab when combined with chemotherapy rather than chemotherapy alone. The PFS improves by 3 months if your CPS is 10 or higher. And again, seems to be 2 months, give or take, if you use a cutoff of CPS 1. 12-month PFS rates were improved significantly by 16 percentage points. If you use CPS 10, it was improved by 9% if you use CPS of 1. The subgroup analysis for progression-free survival is here. If you use 1 or higher, there was a benefit to pembrolizumab. And it seemed like it wasn't any better if you went higher than that. So 10 is here, and then what about 20 is here? And so if you look at these subgroups, it literally looks like pembrolizumab helps everyone when it's combined with chemotherapy. In terms of the safety, I included here, again, you're comparing to placebo, but I think it is noteworthy that almost everyone got a toxicity of any grade with literally the same proportion of grade 3, reflecting the use of chemotherapy in patients with metastatic disease. Now, if you look at the immune-mediated events, these are the ones of interest, and we did see them here. But severe events were not common. Moving on beyond immunotherapy, we do have an antibody drug conjugate that is available for patients with metastatic triple-negative breast cancer, and it's sacituzumab govitecan. This is based on the ASCENT clinical trial. Patients had metastatic disease with no prior treatment line limit, but you must have received a taxane in your treatment for disease. The intervention here was a 2-week on, 1 week off infusion of sacituzumab govitecan. The comparator was chemotherapy consisting of standard options, eribulin, vinorelbine, capecitabine, or gemcitabine. And in terms of the results, I just showed the table review. If you look at the median progression-free survival, chemotherapy buys you 2 months. Sacituzumab gets you almost 6 months. If you don't have brain metastasis, it's really not that different in the full population. Hazard ratios are statistically significant. Median overall survival also significant, an additional 6 months in median, and the hazard ratio consistently statistically significant. A higher complete response rate, higher partial response rate, and a very high clinical benefit, which is response plus stable disease at 6 months or higher. And the duration of response was also doubled. So again, showing a benefit to sacituzumab, even in patients who had brain metastases at entry. Here's just some of the plots that were provided. Again, progression-free survival significantly stretched to the right. Overall survival significantly stretched to the right, favoring sacituzumab. Here's the patients without brain metastases, showing a much higher group of them had a reduction in their tumor versus those who got placebo plus chemotherapy, and then progression-free survival in the full population, which mirrors the progression-free survival in the patients who did not have brain metastasis. This is a subgroup analysis showing benefits in patients regardless of race, regardless of prior therapies, regardless of geography, regardless of whether or not they use checkpoint inhibitors as well. So again, fairly significant results. If you note here, Asian patients, there was not enough people. There were only 18 patients in this trial of over 500. So what you're seeing here in this subgroup analysis is really a low numbers, making informing benefits very difficult. In terms of what this drug does in the toxicity, what you're seeing here, if you just concentrate on the NE grade, it's about a 10% higher toxicity rate compared to chemotherapy alone, including things like febrile neutropenia, anemia, and then neutropenia as well. You do see GI toxicities, most specifically diarrhea and nausea. You're seeing higher degrees of fatigue, and some musculoskeletal issues, which are really not changed. So again, treatment benefits, but still therapy nonetheless with associated side effects. So this is a whirlwind tour. I just wanted to introduce another way we're trying to make decisions in the US where it's not as option independent as NCCN's criteria were. Again, these pathways are being rolled out to reduce the heterogeneity in how patients are being treated across institutions. And hopefully it will help in getting our drugs accessed by our patients with less red tape through insurance agencies here in the US. For this group, triple negative breast cancer is heterogeneous. And I think based on some of this information, we need to employ more molecularly driven diagnoses in our clinical trials and probably in our clinical practice so that we can make better decisions. IO therapy, immunotherapy has become a part of standard of care in the neoadjuvant context for triple negative breast cancers, but also as an option in the treatment in metastatic disease. Whether or not patients will benefit from immunotherapy in the setting of a relapse or metastasis, if they receive immunotherapy as part of curative intent treatment, remains to be seen. Controversial areas is the optimal treatment for those patients with residual disease after neoadjuvant chemotherapy. My bias is against the routine use of capecitabine, but I do discuss this data with patients, and together we make an individualized choice whether to use it. And it's also a question, again, I'm always asking in our tumor conferences, who is appropriate for neoadjuvant chemotherapy versus primary surgery? We at least have one data set suggesting that patients with tumors less than 15 millimeters may not warrant chemotherapy at all. So neoadjuvant chemotherapy in at least that small group may not be appropriate.